Hello, good afternoon, everyone. My name is Dr. Felicia. I would like to welcome all of you to a webinar organized by Beacon Hospital. And we would like to talk about pain management in our setup in palliative care. And it's in line with what we believe, which is to relieve, to comfort, and to care for our patient. Many of you have experience with dealing with patients that have cancer, and one of the greatest fear that they have is actually pain. I'm quite sure some of you have actually heard stories that patients scream in pain, and as medical professions, even as GPs, when my experience was like, we find it a little bit difficult a bit helpless as to how to help our patients and as our friends. So today, we will go into this topic with the intention of trying to educate our GP friends, our healthcare professional providers, so that we can be more sensitive and we can be more quick to pick up some of the issues related to pain and how we can help them. Give a second. Okay, so I would like to introduce two of our speakers today. And we play different role when we are dealing with pain management, and from an oncology side and from the palliative care side. It is a hospital where we truly believe as a team we can work as an integrated care for our patient. So Dr. Junie will be able to share with us her perspective from an oncologist. What are the modalities that she can use to help with some of the pain that our patient is experiencing? And Dr. Koon will be able to share with us from palliative care point of view, what are some of the modalities that we can use together with oncologists to help our patient in pain management. Dr. Junie is one of our consultant oncologists in Beacon Hospital, and she is specialized in treating adult cancer, which involve probably from head to toe. And she is a member of ESMOS and involved in plenty of clinical trial. So she uses different modalities in radiosurgery, radiotherapy, chemotherapy, and she will share with us more how these modalities can help our patient with cancer pain. All right, so I'll pass it to Dr. Junie. Please help me to welcome Dr. Junie to talk about pain management from the oncologist point of view.
Can you hear me? Yeah, sorry for that technical issue. I would like to start again. Thank you, Dr. Felicia, for that very kind introduction. And I would like to welcome everyone for tuning in today. I will start off my slides by explaining what is cancer first. Basically, cancer is when there is an abnormal cell that grow uncontrollably in the body. So as you can see in this picture, this is what normal cells look like. A certain mutation can happen within certain cells in the body and making this cell become growing uncontrollably, and they spread and become more and more, and it can even have invasion further on. There are more than 200 types of cancer cells that are detected, and generally it starts off with certain mutation. And you can see there is basement membrane here. And when the cancer cell breaches through basement membrane, it will be called a carcinoma. Before that, it will be called as a carcinoma in situ, means it has not started to invade into other normal tissues surrounding it. As you can see here, it can breach through normal blood vessel or breach through other tissue organs and breach through basement membrane. And it can spread through other parts of the body. The commonest places that they spread to is to the brain, to the lung, to the liver and the bone. For patients that has tumor spreading to the brain, they can have presentation of headache, vomiting, basically increased cranial pressure symptoms. In the lung, usually they present with uncontrolled cough. Some patients can even have hemoptysis. Lymph node metastasis can present itself with lymph edema, either in the hands or in the limb, upper limb or the lower limb. For liver, generally patients do not have a lot of symptoms unless it is actually very massive or very high tumor load. Patient can have jaundice at that juncture, but sometimes patients actually present with constitutional symptoms like loss of appetite, loss of weight, lethargy. Bone mets usually present itself with bone pain, which is persistent, uncontrolled. No matter what time of the day, it's always gnawing and can be quite severe. So looking in Malaysian perspective, Malaysia has a population of about 32 million, plus minus 1 to 2 million of foreign workers that stay in Malaysia. You can see roughly about 44,000 cases, new cases are reported each year. And from that, about 60% of the patients are actually passing, they pass away because of cancer. And you can see from the pie chart, the top 3 is actually breast cancer. The number 2 is colorectal cancer. And number 3 is lung cancer, as you can see from the pie chart. Unfortunately, because of awareness issue and lack of screening, about three quarter of all our patients that present to a cancer unit or seek treatment, they present actually quite late at the stage 3 or stage 4 disease. Narrowing down to males and females, the top 3 among the males are number 1, lung cancer, then followed by colorectal cancer, and then prostate cancer. Even though the lung cancer numbers may look small to you, but unfortunately for lung cancer, it is the deadliest cancer to have, with the highest chance of death within 2 years of diagnosis. Amongst the females, about a third of the females present with breast cancer, followed by colorectal cancer and then cervical cancer. Cervical cancer is actually highly preventable because more than 95% is associated with HPV virus infection. And this can be eliminated by giving vaccination. And so now Malaysian government has imposed compulsory vaccination for all girls in school, and hopefully in the future, we hope in 10-20 years, the number of cervical cancer patients can be reduced. So in stage 4 disease or metastatic disease, the treatment intent is palliative, which means in this cohort of patients, we actually aim to improve the quality of life and try to prolong survival. Improving quality of life means we control the symptoms, try to reduce the symptoms as much as we can. And there are many treatments that are available even though it is a stage 4 cancer, including surgery, chemotherapy, radiotherapy, hormonal therapy, targeted therapy, and immunotherapy. We'll go through that in the next few slides. So the first one being surgery. Most of the time, surgery is the main treatment for cancer, especially in the earlier setup. But it is also very helpful in the palliative setting, whereby surgery can help by removing the tumor. For example, let's say in a fungating breast tumor, the surgical resection will help with wound care. It will be easier for the patients as well as the carer, and it's no longer foul smelling because the primary issue has been removed. Patient will feel better, and appetite and energy will also improve because they do not need to withstand the odor and fungating mess every single day. It can also be preempt, as in preventing further future issues that can arise. For example, when there is a colon cancer, it is large enough, it can cause bowel obstruction. And surgery by doing a colostomy, for example, can give a bypass pathway whereby we don't go into intestinal obstruction or rupture. Surgical intervention now has much improved, and we can go through with minimal invasive or laparoscopic measures whereby recovery time is actually very short and the operating time is also very short. Chemotherapy is using drugs, for example, to destroy cancer cells. In palliative setting, this is actually very important. It keeps the tumor in check, try to shrink them down, prevent them from growing more, dividing and spreading further. It is a very effective modality of treatment. It can be used in various different stages, whether initial part before surgery to shrink down the tumor, and also killing off small cancer cells that are circulating in the blood and reducing the risk of spread. Or in the palliative setting, most of the time we use it to control the disease, control the symptoms, and in turn, this will help to prolong life in patients. It can be used in concurrently with radiotherapy, for example, to make radiotherapy more effective, or in combination with immunotherapy, which we'll touch about a bit later on. There are a lot of side effects associated with chemotherapy. However, with the very much advancement of treatment nowadays, there are actually a lot of drugs available. We have very good anti-vomiting drugs if vomiting is a fear, whereby some of my patients actually don't feel any nausea, don't feel any vomiting at all. It can cause effect to the bone marrow, like in reducing your white cell count and then hence reducing your immune system. However, there are also drugs that will injectable drugs that can boost that up and improve your white cell count and preventing infection from happening. There are also oral forms of chemotherapy. It's not all necessary to have injection form of chemotherapy, and it varies with different type of cancer that you have. We move on to the newer drugs available, which is targeted therapy and hormonal therapy. Most of these drugs are oral medication, and they are very specific in the sense that they only target certain types of tumor that harbor certain gene or certain protein in that particular cancer. It aids to shrink down the tumor, reducing the cell proliferation and progression, and hence prolonging life. Some targeted therapy actually target environment around the cancer, for example, in the blood vessels and in the bone. So they help to reduce the supply of nutrients to the cancer cell and hence controlling the cancer. Generally, these drugs have much lesser side effects and they are very easy to take and very easily tolerable. And it is specific in the sense that patients generally need to go through a certain type of checking whether they harbor a certain mutation or certain tumor type before they are suitable for this type of targeted therapy. We move on to immunotherapy. Basically, these are drugs that stimulate your own immune system to fight against cancer. So what are immune system? The immune system is like your soldier in the body. It detects and destroys abnormal cells, for example, cancer cells. It will stop its growth preventing it from spreading further. In a normal condition, these are the normal immune system work. However, the cancer cell can have a lot of ways to avoid destruction or detection by the immune system using certain genetic mutation, certain proteins that is expressed by them, and certain change in the environment around the cancer. They try to evade immune system detection and hence eliminate the immune system from killing them off. So there are drugs currently available that will boost up your immune system as well as allow your own immune system to detect where the cancer is and go and attack them. So these are suitable for certain types of cancer, especially now the one that is very commonly used is for lung cancer, stage 4 lung cancers. So I go on to radiotherapy, which is actually one of the most frequently used and most important treatment modality for palliative treatment. What is radiotherapy? Basically, you use very high dose of X-ray to focus on where the cancer cell is and you kill off the cancer cell by destroying the DNA in these cancer cells. We use linear accelerators or called LINAC machines that helps to generate X-rays and focus it very specifically to where the tumor is. It can be used in different stages of cancer, and in the palliative setting, it is very useful in 5 situations. Number 1, to relieve pain. Number 2, treating spinal cord compression. Number 3, treating cancer in brains, for example, shrinking tumor to relieve pressure or blockade and stop bleeding. So for the first one, radiotherapy for bone pain. These are X-rays of patients that actually has cancer and then they have bone metastasis. If you can see here, this X-ray show that the cortex of the bone is actually irregular. It's supposed to be smooth, and you can see there is abnormal thickening, and you can see there is a darker shadow here indicating there is a lytic lesion. These are places that the cancer has eaten up or making the structure of the bone is being very, very weak. So for this one, for example, there is a very obvious fracture whereby the bone has broken because the bone is no longer strong, it's brittle. And in this one, for the pelvic bone, you can see there is actually multiple sites that has bone metastasis, mixed sclerotic as well as lytic lesion. And you can imagine the amount of pain that this patient can have. So radiotherapy, how does it help? So it allows for very effective and very simple pain relief. We give using 1 up to 5 or 10 times of radiotherapy, and about 2/3 of the patient can have moderate or complete pain relief after the radiotherapy. It happens over a few days after the radiotherapy, and this can last for many months. So the requirement for painkillers, for example, can be reduced after radiotherapy, and if the pain occurs again, the radiotherapy can be given again to the same site or different sites. It acts by shrinking the tumor in the bone area, improve the pressure compressing onto the bone or the nerve around there, and allow for a healthy bone tissue to regrow and strengthen the bone again. Sometimes when the bone is fractured, for example, we need to fix the bone, and because the tumor is still active at that area, after fixation, we can give radiotherapy to improve the pain and allow for some form of bone regrowth. Spinal cord compression is actually an oncological emergency, meaning we should have an intervention within 48 hours of diagnosing it, because the consequence can be very devastating. The patient can have permanent weakness or loss of bowel and bladder function, and then they may be paralyzed lifelong after that. So you can see from the MRI, this is a normal bone, a normal bone, seeing from the side. This is a normal spinal cord surrounded by normal CSF within the spinal column itself. You can see this whole bone is actually severely damaged and it caused a compression fracture. And the posterior part of that is actually bulging into spinal canal and pressing onto the spinal cord. And anything below this, the power, the sensation will be reduced because of that. And you can see here, the tumor has taken up almost the whole area of where the spinal canal used to be and has spread to the muscle around and even the part of the rib as well. This is what we do during radiotherapy. We focus our beam into this area that we think will cause issue, will cause pain, will cause that damage to the nerve, and we irradiate this area to help to reduce the damage to the spinal cord. The patient can actually present with acute onset of weakness, whether it's upper limb or lower limb, depending on the level of the spine involved, and sudden onset of unable to pass urine or motion. This is particularly important if the patient has existing cancer before, for example. What do we do? In that juncture, we will need to bring the patient into emergency, do an urgent MRI of the whole spine. Patient, if it is single level, patient may consult the surgeon to stabilize that area with a spine decompression surgery. And after that, we can give radiotherapy. Some patients do not require surgical intervention, can get radiotherapy immediately. Steroids is actually very, very helpful because we know there is a lot of inflammation that happens during spinal cord compression, and entrapment of this nerve will cause severe pain as well as the loss of function. So the steroid will reduce the inflammation and help to conserve the neurology of this patient. For brain lesions, for example, you can see this is a typical presentation of a brain metastasis in the form of MRI. You can see multiple areas of different density. Sometimes they can have peri-lesional edema, where there is swelling. And because of this swelling, the patient can present with nausea, vomiting, severe headache. Sometimes patient can present with fitting as well. And you can see the picture A is before radiotherapy. The tumor size is like that. There's a lot of edema. After radiotherapy, you can see the tumor can actually shrink and the edema around the brain is actually resolved or reduced. So it aims to reduce and shrink the tumor, reduce the symptoms. Some patients, if the edema is very bad, we may need to go in for surgical resection first. And if it is very, just one lesion up to 3 to 5 lesions, very small lesions, we can actually aid to radiotherapy, just the tumor itself without affecting the other parts of radiotherapy. If there are numerous lesions like in the picture here, then we may consider irradiating the whole brain. It can cause some symptoms like headache and nausea, vomiting related to the edema in the brain, but most of the time it resolves spontaneously with the cover of steroids. So radiotherapy can help to relieve pressure or blockade. Certain tumors that grow, they cause a local compressive symptoms. For example, they can compress onto the trachea, esophagus, the bronchus, or blood vessels. Radiotherapy can help to shrink down the tumor, and in turn, this will help to relieve the obstruction, and patient with the relief can improve on breathing, on swallowing, and reduce in pain or feeling of breathlessness. So for one important example is SVC obstruction. So as you know, this is your vena cava, your superior vena cava is around this area, and it helps to supply back the blood, the return blood from other parts of the body and the lung to enter into the heart again. So when there is tumor around that SVC region, it causes compression and the blood flow there will get sort of stuck. And in turn, the patient will have facial puffiness and then swelling of the blood vessel around the chest wall, etc., causing them to have pain and dyspnea. It's very common in lung cancer and lymphomas. So these are the typical symptoms. As you can see, the face of the patient can get very red. can get swelling, and then if you can see, there are actually dilated blood vessels around the chest wall. The IJV can get distended. Patient can have hoarseness of voice as well. Radiotherapy will shrink this tumor and help to improve the blockade. Symptoms can also improve with steroids and with a PPI cover, the gastric medications. Radiotherapy also plays an important role in stopping bleeding. So you can see from the picture, this is a breast cancer patient with a fungating breast mass. There's a lot of swelling. These are all tumors involving the skin. And this is a gastric tumor whereby the doctor do a OGDS, and you can see there are actually grape-like tumor in the stomach with active bleeding. This is a buccal mucosa tumor. You can see there is a fungating lesion here, and this can cause a lot of bleeding, foul smelling, and prone for infection. So why does this happen? Because when tumor grow very fast, they have very abnormal blood vessels. These blood vessels are not your normal blood vessels. They are very unstable, very friable, and they can bleed instantly and uncontrollably. Sometimes when the tumors shrink because of chemotherapy, etc., the abnormal blood vessel get exposed because of the tumor shrinking. That itself also can cause some form of bleeding. Very common cancers that can cause bleeding is, for example, cervical cancer. They can have vaginal bleeding, vaginal discharge. Radiotherapy can be part of the radical treatment for cervical cancer itself, or as a palliative measure to stop the cancer from bleeding. Bladder cancer present very frequently with hematuria, bleeding in the urine. And of note, this one you need to be careful. Try not to give tranexamic acid to stop the bleeding in this case, because tranexamic will cause blood clots. And when the bladder is filled with blood clots, the patient will not be able to pass urine, and you need a bladder irrigation. Stomach cancer, like I mentioned, we can give radiotherapy to stomach cancer in a palliative manner, means just to stop the tumor from bleeding. Usually the bleeding will stop within 5 to 7 days after the radiotherapy. So if you think there is a massive bleeding that is happening now, patient look anemic, can kick sick, so you need to give OGD first and try to give injection, for example, to stop the bleeding. This will prevent the patient having active bleed, meanwhile while waiting for the radiotherapy to work. Fungating and bleeding breast tumor, head and neck cancers like buccal tumors here. Lung cancers can have bleeding, especially the tumor is near the main bronchus. Radiotherapy can help. Skin cancers after surgery or even without surgery can be treated with radiotherapy. As such, I would like to summarize that palliative treatment and palliative care doesn't mean that there is no longer any treatment option for the patient. There are still numerous treatment options available to help the patient to improve their quality of life and improve their symptoms. There are many new drugs and new radiotherapy machines, surgical techniques that can help improve cancer care, and also many drugs available to counteract all the side effects that can happen with our treatment. Sorry. Even in the advanced stage, treatment can improve symptoms and improve the quality of life. And I truly believe as a physician, only sometimes we can cure. Often we try to relieve the patient, and we always try to comfort patients. With that, I thank you for your attention.
Thank you, Dr. Junie. It is very informative. I think even as a palliative care physician, when I was very much earlier in my practice, I was always wondering why oncologists is still involved in seeing our patient, even at stage 4 or very advanced, or even at the very last few weeks. As I start to work together with the oncologist, my colleague, I understand that a lot of palliation can be done through their expertise, especially as what Dr. Junie have shared, radiotherapy for pain management, as well as pain related to the intracranial, what they call the tumor, that will be relieved very much with radiation. So thank you very much. We will keep the Q&A to the end of the session, but I'd like to introduce you to our second speaker.
Hello, everyone.
Wait, I'm just going to, sorry. The second speaker is my colleague, Dr. Koon. Dr. Koon is one of the palliative care consultants in Beacon Hospital, and she works very closely with me and all the other oncologists in this hospital to provide palliative care. So she specializes in palliative care, and she sees patients that has cancer and non-cancer as well. She believes that, you know, to take care of a patient, even in pain, it has to be told in a holistic care, in total care. And she is experienced in using acupuncture in managing pain in our patient. So I would like to let Dr. Koon teach our mind as how palliative care has a big role in also managing pain in our patient. I'll just pass it back to Dr. Koon. Simran, please go ahead.
Yes, good afternoon, everyone. Welcome to our webinar today. And thank you, first of all, to Dr. Felicia and Dr. Junie for your kind sharing early on. So today, I would like to focus mainly on improving your understanding about importance about appropriate assessment and diagnosis of pain, particularly in patients with cancer, and help you to recognize the causes of pain in cancer patients and the concept of total pain. And lastly, I hope by the end of the day, you have a little bit more understanding about the principle of pain management and using the different methods, including pharmacological and non-pharmacological approaches to pain management. So I would like to start, first of all, by looking at the definition of pain. There's so many very different definitions out there, but what I really want to say is pain is what the patient or the person that experiencing the pain say it is. This statement is really just to highlight the need for doctors and nurses to listen carefully to what the patients say about their pain in a really non-judgmental way. So how common is cancer? How common is pain in our cancer patient? Relatively common. So it happens in about 60% of our patients, and different type of pain may relate to different kind of problem. It could be because of the cancer itself. It could be because of the consequence of the treatment of the cancer. It could also be pain that the cause is not related to cancer itself. For example, 15% of these cases is exactly like that. The pain could be related to infection, where you could treat and improve. Pain could be related to existing chronic diseases, for example, osteoarthritis or any joint inflammation. And quite often, there are more than one type of pain at one time. So let's look at how we classified different type of pain. You can classify pain according to the location or the structure that's been involved. For example, muscular pain, headache, liver capsule pain, bone pain, and nerve pain. You can also classify pain according to the cause. Like I mentioned earlier, it could be the cancer, it could be the existing diseases, non-cancer diseases, or because of a side effect or complication of treatment. It could be functional or pathological, or it could be nociceptive and neuropathic. Now let's look at nociceptive and neuropathic pain. If you remember back at your medical school time, you probably learned about how these two different types of pain present themselves. For example, nociceptive pains are associated with tissue damage or injury. It can be breaking down to somatic type of pain or visceral type of pain. So a patient might present themselves or give you a history of a constant ache, or whether due to a visceral type of pain, where they might describe it as a constant aching, gnawing type of pain. And if it's a muscle or a bone that's involved, patient still may describe it as an aching type of pain, but may be related to movement. So neuropathic pain is due to an injury or compression on the nerve, or with the nerve being irritated in some ways. Patients often present the pain or would describe the pain as sharp, shooting, stabbing, it radiates, follow a pattern of the nerve that's been affected. And sometimes patient even could tell you that the areas been affected are quite numb or tingling sensation. And on examination, you may find as a reduced sensation or hyper sensation in that particular area. So the next thing I want to talk to you about is really the concept of total pain. So what exactly is total pain? Total pain, by definition, is how one perceives pain or how we experience pain are not only based on the physical causes. Our perception of pain are highly influenced by our psychological state, our emotion, spiritual states, and sometimes even social circumstances. For example, if you are feeling more anxious, if you're worrying about things, your pain threshold or your pain level may increase. So what about the general principle about pain management? I needed to say that for pain management to be effective, it is crucial that you perform good assessment of pain. So, and always remember the concept about total pain, not just checking on the physical causes of the pain, think about the psychological, emotion, and also spiritual causes to one pain. And by always, explain and reassure the patient about the pain and that you're here to help them. And the first principle is you may want to, now you know that the cause of pain, think about whether you could reverse the cause of pain. Like I said before, 15% of our patient pain in cancer may not be directly linked to the diagnosis of cancer itself, for example, infection, and that could be easily reversed. There's also other conditions within cancer that is easily reversible that will improve patient comfort and pain, for example, hypercalcemia or pathological fracture. And when you think about managing a pain, you need to think about both pharmacological and non-pharmacological intervention, which I'll tell you a little bit more later. So good assessment of pain. So general questions, when you see somebody in pain, first question that you ask, which is pretty obvious, but are you in pain right now? And the next question you may be able to ask is how severe is the pain? And you may be able to use visual analog skills, asking patients to score the pain between 0 to 10. And sometimes that can be quite hard for certain patients. And you may want to use a different scale or score instead by asking them to rate it between mild, moderate to severe. And asking the patient where do they think the pain is coming from. Sometimes our patients know a lot more than we think they do. So asking the general question may help you with your assessment. And think about assessing the emotional, spiritual, psychological aspect of the pain. In your busy clinic or your busy clinical work, you may not have all the time to ask this question, but it's nonetheless, it is important. So there are tools out there to try to help you to assess pain. One of the most commonly used tools is by asking the patient themselves about their pain. But sometimes they may not be able to answer you. It may not be as simple. Then you may want to ask a carer or getting a collateral history. If you have previous documentation of pain, looking at the body chart, then you can understand previous assessment of pain. You may ask the patient to score the pain using the visual analog scale or using categorical skills. You may ask the patient to keep a pain diary, and I do it quite a lot with my patient in clinic, in that patient will record on a day-by-day basis when they're not in hospital or in clinic, how their pain like on a daily basis, and also how helpful when they do take their painkillers. Pain questionnaires are mainly quite comprehensive, quite long, and mainly more appropriate for research purpose. And this is the common tool assessment that you may have seen. The one on your left is obviously a lot more comprehensive. The one on your right our visual analog scale, your categorical scales. But most importantly, I want you to point your attention to the face scales or the face assessment tool, where you could base on our patient's facial expression to let you know how severe is the pain. So what are the challenges or problems that you may encounter when you want to assess their pain? Quite often the patient may underpay their pain, or patient might react markedly to their pain, and that could be due to influence by their psychological state or emotional state. So it's important for you to try to unpick that. It may be that the patient is unable to give you a clear history about the pain. Maybe it's communication issue, maybe it's language barrier. And then you may want to take a collateral history from the carers or their family members. But sometimes when they don't have any loved one with them, they don't have the carers, don't have a family member with them. So how do you assess pain in this sort of situation when the patient is unable to communicate with you or language is a barrier? And then we can look at how else we can assess one pain when they cannot use words. Take a moment to think about in your clinical practice what you would do when you're trying to assess patient when they're having pain in this situation. You may want to look at their facial expression. They may be frowning, they may be grimacing. To an extent, they may be crying. Their behavior might change. They may keep really, really still, different from their usual behavior. They may be very guarded when you try to go near them, when you try to examine the affected area. They may be seen rubbing the painful area. Their behavior might change, like I mentioned early on. They may not want to participate in activities that they used to do. They may have rocking or clenching fists. All these are important features to look out for, particularly where they cannot use words to express they're in distress. You may also able to detect some autonomic signs, for example, sweating, pale looking, their pulse may be racing, the breathing may be panting. So all of these signs will be useful for you to pick up that they are in pain. So first of all, how we start to help manage our patient pain, we need to know, as best of our ability, from history taking, by assessment, by examination, even by investigation, to find out exactly what the cause of pain it is. So it could be, the pain could be pain or movement, and that could be related to muscle or bone. The pain from your history may be worse when they take a deep breath, and that may be due to pleurisy or due to lung irritation, or they may describe the pain come and go like a waves or crampy type of pain that often could be caused by simple things like constipation, or could be due to tumor in the bowels or bowel obstruction. And they may tell you that the pain, the certain part of the skin may feel tingling or maybe numb, and that could be due to a nerve being irritated or damaged. When a patient mentions that they've got pain, giving strong painkillers might not always be the best solution. So what practical things that we can do immediately when you see somebody with pain? Obviously, to find out a little bit more about the pain, listen to their fears, reassure them, and maybe try to position them differently. You'll be surprised by doing simple things like that, how much you can make them feel a little bit more comfortable. And obviously, think about using painkillers, whatever that is available, mild, moderate, strong painkillers to try before you try to examine them, move them, or send them for any investigation. So let's look at how we use pharmacological treatment to help manage our patient pain. So I would like to point your attention to the WHO ladder. Most of you will heard about WHO ladder, and today is just a refresher of what you're understanding about WHO analgesic ladder. So as you know, WHO analgesic ladder has been in our medical field for 30+ years. So there's it consists of 3 steps. So first step is a non-opioid. When one pain, ideally you want to start them on a non-opioid step 1 analgesia. If the patient's pains are no better, you then move on to step 2, where you add in a weak opioids. And when pains are still no better, despite being on a non-opioid, a weak opioid, the next step is to substitute the weak opioid to a strong opioid, but still able to maintain on your non-opioids in step 1. In our cancer patient, if they present to you with moderate to severe pain, you can actually skip step 2 and jump from step 1 to step 3. And bearing in mind at all times, think about the adjuvant, which I will talk to you a little bit later, throughout this process to try to improve our patient pain. So let's have a refresher about what classified as non-opioids and what classified as opioids. So your non-opioids is your paracetamol, aspirin. They do have a ceiling dose. Weak opioids is your codeine, dihydrocodeine, and tramadol. Again, all these three medications would have a ceiling dose. Strong opioids, commonly you will see is morphine. You also might have heard about oxycodone, fentanyl, or maybe buprenorphine. And fentanyl and buprenorphine are in a patch form. You may or may not heard about methadone and hydromorphone, and it's mainly quite commonly used, more commonly than in Malaysia, in use in United States or in a European country. So adjuvant treatment. So what are adjuvant treatments? So adjuvant treatments itself are pharmacological treatment. They themselves are not analgesia or painkiller per se, but it has a role in improving our patient pain. For example, antidepressant, the like of amitriptyline and duloxetine are particularly useful in neuropathic pain. How you may ask, how can an antidepressant or anticonvulsant be helpful for pain? To answer that, you first of all may need to recall how your pain pathway happens. So when one has a stimulus of pain, you may remember this, the ascending pathway through this spinal thalamic tract all the way up to your somatosensory cortex and down the inhibitory descending pathway where our body tries to modulate the pain. So antidepressant and convulsion work on these certain pathways. So for example, antidepressant, the like of amitriptyline, duloxetine, work on the increasing the amount of serotonin or noradrenaline, the nerve ending of the inhibitory process. And anticonvulsant in the like of gabapentin or pregabalin is one of the two common anti-epileptic that we use. And it works by reducing the neurotransmitters and the nerve ending in the ascending pathway. So we sort of reduce the signal, a pain signal traveling up to our brain. So other adjuvant that you may see and helpful in our cancer patient, particularly bone mets, is bisphosphonate. So how bisphosphonate helps? Mainly acting on the osteoblast and osteoclast activities. So the whole aim of it is to strengthen the bone in bone mets and stop the breakdown of bones. With that, it helps improve our patient bone pain. NSAID, the like ibuprofen, diclofenac, Cerebrex, or naproxen, and help resolve anti-inflammatory process, reduce the prostaglandin and substance P release, hence in helping with all this inflammation pain, for example, joint pain or bone met pain. Corticosteroids in the like of dexamethasone or maybe prednisolone, it used to help to reduce tumor swelling, may reduce pressure, reduce compression on the nerve that's been affected. You may also heard about a muscle relaxant, the like of benzodiazepine, diazepam, and also baclofen, and helping muscle spasm and cramp. And you may heard about buscopan or hyacinth butyl bromide is a smooth muscle relaxer. It mainly just to help our patient pain due to colic, mainly contraction in the bowel walls. You may or may not heard about NMDA receptor blockers. It's particularly helpful in neuropathic pain. Same pathway of how gabapentin and pregabalin works, help by reducing a level of neurotransmitters in the ascending pathways, reducing the pain signal going up to the brain. The common NMDA receptor blockers that you may have heard of is ketamine. And I need to emphasize that ketamine are only by specialist use only. It's not often our first line of treatment. It was only when all other common adjuvants fail, then we may consider using ketamine. So let's look at strong opioids together. So morphine is still the opioids of choice. I will tell you a little bit more about other opioids. Morphine is still the opioids of choice. It's been around for a very long time. Most physicians know how to titrate them. If you're being used correctly, an appropriate dose, titrate carefully, is well tolerated. At the starting dose, you may want to consider 2.5 milligrams all the way to 5 milligrams, but you may need to use lower dose in a frail elderly patient or patient who have renal or liver impairment, as low as 1 milligram as required. Consider conversion to a modified release morphine. Why would I say that? Morphine, in the like of morphine syrup, is what we call a quick acting morphine. It goes into the system quickly, but it's there to stay for a few hours, and before long, the effect will wear off. Our modified release preparation ensure that continuous amount of morphine going through our patient system over 12-hour basis, for example, using MST. And although our patients are still on a modified release regular morphine, you can still have another breakthrough dose of morphine if needed. To calculate that, it's 1/6 of the total daily dose. What about the alternative to morphine if a patient have intolerable side effects from the morphine? Yes, there's other things that you can try. For example, oxycodone is one of them, but please be mindful that oxycodone is twice as potent as morphine. So for example, 40 milligrams of total morphine daily is equivalent to 20 milligrams of oxycodone daily. I would not suggest when a patient is in an acute pain and when you try, or in a condition where it's unstable pain, to start with transdermal batches, for example, fentanyl buprenorphine, and I would explain to you why. So fentanyl patch, some of you might have heard about it. It is a strong opioid. Like I said before, it's not quite really ideal in an unstable or acute pain situation. Why? Because when you start patient on the patch, it takes 12 hours to 18 hours to really reach the peak of pain relief. And the patch needs to be changing every 72 hours. It could be temperature dependent. Sometimes the patch might not adhere properly. It might get stuck to the clothing. When they change, the patch get removed with it without patient aware of it, and there's no longer pain relief continuously in the system. Fentanyl patch also, we need to be careful, is definitely more potent than morphine. So the smallest dose of patch that available in the market, even 12 micrograms, is equivalent to 30 milligrams of morphine in 24 hours. 25 microgram patch equivalent to 60 milligrams of morphine over 24 hours. However, fentanyl are still very helpful in certain circumstances. For example, particularly patient can't take medication orally or can't absorb painkiller orally, then they're particularly helpful because it is a patch, it gets absorbed to subcutaneous tissue and then through the rest of the body. And fentanyl patches are particularly safe in renal and also liver failure. So let's look at one non-pharmacological treatment that is available. When we're looking at the concept about total pain, it's important that we offer psychological intervention, for example, relaxation techniques, CBD, cognitive behavior therapy, to try to help our patient managing their pain, particularly there's an element of anxiety. You may want to consider physiotherapy, right, repositioning by using walking aids, trying to improve their mobility, using wheelchair, trying to help them with that. You may heard about TENS machine, which is a mild electrical current being passed through the patch via machine, and that's particularly helpful with muscular type of pain. Acupuncture, I use that to help with my patient, particularly in some muscular skeletal pain, and also in circumstances where our patient have neuropathic pain. And Dr. Junie have already shared with you how radiotherapy and chemotherapy are helpful in terms of managing our pain. And Dr. Junie also shared with you how surgical intervention will be particularly helpful. For example, in cancer pain, for example, debulking surgery or surgery where you have spinal collapse, you can have vertebroplasty or spinal stabilization in helping our patient pain. You may want to consider nerve block where a patient's analgesia, oral analgesia or pharmacological treatments are not particularly getting on top of pain when patients have lots of side effects. Nerve blocks such as brachial plexus block, cedar plexus blocks are helpful in terms of pain. They also, in a rare circumstances, you can have delivery of strong opioids and other local anesthetic, including anti-inflammatory, through the epidural and trying to manage our very, very complex pain. It's not very commonly used, and we need the anesthetic team to really support this where we use epidural continuous infusion of a pain relief. And You may encounter a situation where there is opioid-resistant pain. So when that happens, I urge you to consider, are you underdosing the patient? Have you thought about the 3-step in WHO ladder? Have you moved on to the next step? Think about, is that a poor absorption or poor intake, non-compliance? Are you ignoring the total pain concept? But there are some pain are not particularly opioid sensitive, for example, bone pain, nerve pain, neuropathic pain, muscle spasm. All of them, you need to think about adding in adjuvant in helping this type of pain. This is a few resources that I find it helpful myself, and also helpful when I previously doing teaching and talks. Feel free to go on it and have a look. 2 of them are free. One of them is some small fees to pay. So they are e-learning modules to help you better understand about pain management. I will stop here right now, and thank you so much for your attention. And I will await your question later.
Okay, thank you, Dr. Koon, for a very good message for all of us. So palliative care is really not just about giving you morphine, right? So there are a lot of other ways that we can deal with pain. So from Dr. Junie's talk, we understand that there are a lot of intervention that we can be done either through chemotherapy or radiotherapy that we can use to manage the pain. From Dr. Koon's side, we understand that they are non-pharmacological and pharmacological way, but they are a concept called total pain. So understanding all this, the most important thing is to be able to get a good pain history, to assess the pain properly and see which one of us are able to help. So I will go through some of the questions that is been posted. I think the first one, Dr. Koon, this question is for you. So the question is, my wife has pain in the left gluteal region and all the MRI and X-ray and blood tests are shown to be normal. They have consulted orthopedic, neurologist and several physical sessions. I think probably that means that it is physiotherapy. And the question is, has acupuncture has any role and how to contact you for appointment? So the question is directed for Dr. Koon.
Yes, so it sounded like a very terrible time for you, such a complex pain when you go through very different investigation, it yelled nothing. Yes, first of all, to understand whether acupuncture is going to be really helpful for this gentleman's wife's condition, we need to really first of all examine your wife properly. So I can't really give any advice at the moment. However, I can give you a brief idea of how acupuncture helps. So acupuncture helps with musculoskeletal pain. It helps resolve neuropathic pain as well. For example, sciatica pain, where you may have wear and tear condition in your degenerative spine disease, where your nerves being irritated. Acupuncture will be able to help relieve some of that. But I urge you to consider any other non-drugs measure as well. And I think you've been to physio and see whether by positioning or exercising will be really helpful. I think it needs to be case by case basis without looking at your scan result, without examining your wife. I don't feel that I can give you a very clear answer at the moment. Is that okay?
I think if for the appointments, I will give you some context at the end of the session that you probably would like to make an appointment to see Dr. Koon so that your wife can be assessed appropriately, and she probably give you her expert opinion then. So the next question I would like to, there's not much question from the chat line. So I would like to ask Dr. Junie some of the questions that my patients have been asking us. Okay, Dr. Junie, you know, we were talking about radiation, especially for bone pain and especially for SVCO. And we find that some of our patients complain that during the treatment, their pain experience actually escalate. Would you like to help us to understand why and what can be done to reduce such pain?
Excellent question. Thank you, Felicia. So pain generally arises when there is nerve entrapment or there is a lot of inflammation around that nerve. That's why the patient will experience shooting pain, radiating pain as such. So during radiotherapy, especially the first couple of fractionation, they can induce a little bit more inflammation around that area. So in essence, when there is more inflammation, the nerve get more trapped. That's why the pain can be increased during the first couple of sessions of the radiotherapy. Most of the time when we foresee this type of issue, we would actually give some steroid, for example, dexamethasone, with PPI cover, for example. It will help to reduce the inflammation around that area and prevent further inflammation around that area. And hence the inflammation can be controlled and the pain can reduce. The effect will come around fraction 3, fraction 4, whereby the pain would actually improve with that. Sometimes the patient can even have pain improvement whereby the analgesia they are on, the painkiller they are on, can be reduced. Of course, if there is a mechanical form of pain, whereby like compression, for example, or there is a fracture, the movement of the bone rubbing against each other, that will induce the pain. So in those cases, probably surgical intervention like fixing the fracture or fixing the spinal cord compression, that will relieve the pain and the mechanical trapment of the nerve. I hope that's helpful.
Thank you, Dr. Junie. I think this question is just follow up for Dr. Junie as well. For radiotherapy, what is the minimal hemoglobin level needed for effective treatment, especially during active bleed?
So radiotherapy, it's best effective if your HP is high. Anything more than 10 grams is actually very effective because it is in an area that is low in oxygen concentration, like when you have anemia, the radiotherapy cannot work very, very well. So effectively, if you can get HB above 10, that is well and good. But anything above 8.59, I think that is fairly acceptable. Because sometimes if the patient is having massive bleeding, it's sometimes quite hard to bring it up very quickly over a short period of time. So for example, if gastric bleeding, then we would advise for OGD urgently. They might need to give injection, for example, that will stop the bleeding. In the meantime, while you can transfuse and we can arrange for the appropriate radiotherapy planning and radiation.
Okay, thank you, Dr. Junie. Dr. Koon, this question is for you. Dr. Koon, nerve block or epidural, are these not considered non-pharmacological treatment? May I know what medicine is always used?
So when I mean by non-pharmacological treatment or pharmacological treatment, it's mainly systemic analgesia. So when you take the analgesia, it had a systemic effect. That's what I mean by pharmacological treatment. So I classify nerve block and epidural are delivery of certain medication, which I will share with you later what type of medication it is, directly at a certain part of the area without causing a systemic effect. That's why I classify as non-pharmacological treatments. So for example, nerve block, like I mentioned earlier, celiac plexus blocks, for example, where our patient might have apical lung tumor compressing on the brachial plexus, and patient might experience shooting pain down one limb, and this is despite radiation and chemotherapy. Pains are really no better. You can try oral analgesia, it's not getting any better. Patient have lots of side effects. Then you can contact a anesthetist, and they will be able to inject some local anesthetic and anti-inflammatories. Most often there is steroids to the brachial plexus area, and the local anesthetic then will act to numb that particular path of the nerve, and that effect sometimes could last for a couple of weeks, and procedure can be repeated. It's a very straightforward a day case procedure. Epidural is a delivery of either local anesthetic or opioids directly to the level of the spine where we know our patient have pain. So like I said, it's a very highly specialized procedure. You need to have a good anesthetic team support to have it done. It's not at all common in Malaysian settings, but I've seen it before in a European setting. So what is it exactly? So when opioids are being delivered directly to the epidural space, it's 100 times more potent than oral opioids. So for example, a patient might have increased the morphine level, let's say for example 100 milligrams BD, and still having lots of pain and beginning to have side effects. Then by delivering of a small continuous 1 milligrams morphine directly to the epidural space, it will help with the pain where the level that you want, or in the spine that you want to numb, and sort of reduce systemic effects. Like I said before, it is only a last resort for a very complex pain situation, and you need to have very good anesthetic team in support of delivering that.
Yeah. Thank you, Dr. Koon. Just to add to it, when I was working in Selayang, we used to do epidural for our patient, especially those with very severe pain that even with a very small increase of our morphine, oral morphine or injectable morphine, they become very groggy, they become very drowsy. And yet we know that they have very short prognosis of 3 months. Then we say that why not we just put in an epidural, put a little bit of buprenorphine, put a little bit of morphine, and a lot of them have good quality of life. But one of the downside is probably the numbness that is going to be below whatever level that was being blocked or that was being given the epidural. The reason is because we actually kind of like, put the nerve to sleep. So some of my patients actually says that, oh, the numbness is more troublesome than the pain. So these are some of the things that we need to manage their expectation. So before we do any interventional procedure, it is very important to actually counsel them, to give them what is going to happen and what are some of the effect that is coming with it. So I think this is very important so that we just don't offer, as Dr. Koon have mentioned, it's a very complex symptoms when our systemic medication is causing a lot of side effect. So not everybody can proceed with the block or the epidural. So we need to counsel and we need to manage the expectation. So Dr. Koon, this is patient. I think this one of the question comes from Joey. Does the pain management for cancer patient will cause organ slow down function? I guess what it meant is, will pain management affect your organs? Will that damage your kidney or your liver?
Yeah, good questions. First of all, I would like to say that most drugs, and including analgesia, strong opioids or weak opioids, do have their own set of side effects. But your question directly asking me whether it has permanent or long-term damage onto specific organ of the body, I don't believe so. For example, you may worried about whether the long-term effect on the kidney function or liver function. For opioids like morphine, oxycodone, no. However, we need to use that carefully if a patient have existing liver or renal impairment that I already shared with you early on. Try to use the lowest dose possible if a patient have renal or liver impairment. And you may want to consider different type of opioids like fentanyl if a patient have really in renal failure. I hope that answers your question.
So basically, what our experience is, if you already have renal or liver failure or impairment, we are very careful on our dosing and the frequency that we use. But if you have not have any damage to the kidney and the liver, we can use the normal dose. It doesn't really affect I'm talking about opioids. But be very careful on using NSAID. We do see a lot of polypharmacy, especially when patients have bone pain, nerve pain. So we have probably 4 or 5 medication used to control pain. So sometimes the family member will go and say, oh, can we put a koyo, sometimes we just put another NSAID patch. So if patient already have existing NSAID in the system, then another additional cream or another additional patch that contain NSAID may actually aggravate the GI symptoms. You may actually have small bleed. So be very careful when we are trying to use multiple medication and analgesia to control our pain in our pain management. Okay, I think I would like to pose the next question to Dr. Junie. I think we're coming to near the end of our Q&A. These last two questions will be probably to see how GP, see, GP is our front line. A lot of places that we know there is no hospice coverage, there's no palliative care coverage. So GP will be our first line of helping us to be able to help patients in the community. So for Dr. Junie, would you be able to guide us? What is the role of GP in helping us to detect emergency, like what you have shared, the spinal cord compression, or if there is a massive bleed, or if it's an SVCO? How can our GP colleague help us in the community?
Yeah, very prudent questions, because sometimes the patient do not know. They just go to the nearest GP and then seek for questions that they think they are not sure of. So I think there are only several emergency in oncology that we need to be very aware of. One is being aware of, then you will ask the appropriate questions actually to the patient, and you can actually lead on to getting the proper diagnosis. So especially if the patient have existing cancer before, patient suddenly present with symptoms like numbness, weakness, sudden loss of bowel or bladder control, then you, at the back of your mind, you must always think, is this a cord compression? So that is a golden opportunity of that particular 48 hours only that you can tackle with compression, and you can reverse it even fully, regaining all the neurology if you are still within that time frame. So identifying that this is a possible cord compression, for example, then you may want to consider starting the patient on some steroid. The common one we use is actually dexamethasone, even 8 mg BD, for example. Always cover with PPI, because these patients, they are already stressed. They can get upper GI bleed very easily. So either ranitidine or omeprazole or whatever modalities that you have there, and refer them urgently to the nearest center that has MRI facilities, for example, or neurosurgeon facilities, whereby proper assessment is one thing. The other thing is also we need to do a immediate or proper scan for these patients to rule out whether this is a cord compression. Cancer patients also can have disc prolapse and things like that. So we need to rule out whether this is a cord compression first, and depending on the scenario, whether we need to go for surgical intervention or whether radiotherapy will just be adequate. So these are the things. Massive bleeding, usually if there is the overt tumor, a breast tumor that is bleeding, patient will tell you there's bleeding there. Then you do adrenaline packing or compression, then that will probably stop the bleeding. Check the HB, the vital signs of the patients, whether it is low or whether need acute resuscitation, and refer to emergency, for example. And if it is upper GI bleeding, for example, there is an existing stomach or esophageal cancer, then again, assess the vital signs and then give drip or transfusion as necessary. In GP setting, that may be a bit difficult, so I think we'll still be referring out to hospitals that have facilities. And just by checking whether patient stable or not for transfer, that is already important. Giving a heads up to the casualty, saying this is patient is coming in for this, and getting them ready for that. Tell the patient, do not wait on it. If they say they do not want anything, they go home, they might have massive bleeding at home and then demise at home as well. So other than that, SVCO, usually it's a gradual symptoms. Patient gradually get facial puffiness. The dilated vessels usually means that there are collaterals happening within the body. So it's not something immediate, and more commonly is associated with lymphoma or lung cancers. So that could be one of the indication of starting having the disease, patient not prior diagnosed yet. Smoking history can be helpful, and just a normal chest x-ray to see whether there is a mass, because SVCO tend to have a large mass in the upper lobe region on the right side. So these are clues that tell you this could be a problem, and refer out. Steroid can be helpful for SVCO as well. We also use like dexamethasone 8 mg, for example, that will help to relieve the symptoms of the patient sometimes. Morphine also can help by reducing the sensation of breathlessness, but that usually comes with the proper diagnosis, as well as it will be started by either oncology or palliative. That would be a more rather than just starting off by a GP alone. I hope that can help with understanding the symptoms that can happen with all these oncological emergencies. Yeah.
Thank you, Junie. So the message is have high index of suspicious. If this is something that you see from a cancer patient having new symptom, you're not sure, please refer out. You can go to the hospital that they come from. For example, if they already seeing someone in UM, just go to the UM emergency. All right, if they, whichever hospital they are coming from, just send them back if you are not sure whether this is a cord compression or not. All right, so we always believe in spinal cord compression. We always say if you walk in, you walk out, you know, but if you come in a stretcher, then the chances of recovery is much lesser. So if you can detect it very early, you can actually improve someone's mobility and improve their quality of life. So the last question I would like to direct to Dr. Koon. Dr. Koon, you know, we really talk a lot about the pain management in the community. Not because we are all in a hospital setup, it's easy for us because to assess opioids and to assess pain analgesia is quite easy. How about those doctors, the GP in the community? How can they be part of our team to actually manage pain management in the community?
So I should really unmute myself first. So what I want to say is that every patient has a right to be pain-free. So it means that all doctors should have a basic knowledge of managing pain. It's our role to try to reduce patient pain and comfort. But I completely understand when you are in the community, you may suddenly see a patient on a type of medication, particularly strong opioids that you may not have experience with, and you may feel out of your comfort zone, the dosage a little bit high. Always ask and assess. So the basic information is assess, see what relief immediately that you can relieve, like repositioning, using their existing painkillers. So, and also when our patient have some strong painkillers that you may not be aware of, often someone would have prescribed it. Let's say, for example, find out from the patient where they have got their strong painkiller from. Are they from the local hospices? Is that from the hospital? If so, who would that be? The oncologist, the general physician? And you never know, it may be that they're being looked after by a palliative care doctors. And you, by knowing that, you could also phone the prescribers, the physician that prescribed the medication, and ask them for clarification about the dose. And you may also able to get some help in terms of managing their pain. Now, that will be my view. So not to be afraid of strong opioids. You have a role to try to help us monitor our patient pain in the community. If so happen that you see one of my patients, then please, if you've got any query, I will really welcome your question, and we can look after our patient jointly, both in the community and also hospital. Yeah.
Okay, thank you, Dr. Koon and Dr. Junie. And for my personal experience is, I would like to share a simple story. I have a patient that come in with breast cancer and bone mass, severe pain. You know, even with a slight movement, there's a lot of pain. So we got her to get some radiotherapy for the bone mass, get some opioids and some NSAID in, and we discharged her. She's quite well. And then I met the family. Then we discharged her to the community. But a few months later, the family member came and said that that treatment itself, the pain management itself, have brought them 2 months of good quality of life. She can do a lot of things without pain, and that memory, the last few months of memory, is very precious to the family, and they grieve better. So just bear in mind that there's a lot of things that we can do to ensure that our patient received a good pain management so that they improve their quality of life. So we wanted to just remind again that the oncology and the palliative care team can support in terms of pain management for our patient with cancer. I would like to also just bring your attention to two of our CSR program that we are offering from the 15th of June to the 15th of September this year, where there'll be free consultation to see our oncologist, Dr. Ng and Dr. Junie, if there is any question in relation to cancer, whether it is the beginning of the journey or in terms of other symptoms. And also with Dr. Koon, she will also be able to assist you if you have pain or if you have issues related to palliative care or end-of-life care. So these are the two CSR programs that we are running currently with Beacon Hospital. And just to say that for you to contact us, all right, we have this care line, the general line that you can actually get hold of it, or you can just email to the info beaconhospital.com.my or to the medical license. If any question related to pain management that you would like to direct to any of us, they will contact us and we will reply to those emails. And we're going to finish now. We would like to thank you to all the participants for taking your precious time to join us this afternoon. And a big thank you to Dr. Junie and Dr. Koon for their very informative and important and very comprehensive presentation. So with this, I'd like to say good afternoon and have a good day. Thank you. See you soon.
Just leave her.